So thank you very much for inviting me to talk about the ILC's perspective on chronic pain. I've listed Ehlers Danlos because as most of you know, that's a primary focus of ours. We have ILC operates under 3 divisions for chronic pain, EDS, and research. And we're starting to move more work on the research side because it's highly needed. So that's why I'm listing it here. You know, when we talk about chronic pain, in my world, I think about it in terms of physical disability and the invisibilities of chronic pain. And you know, for the person that lives with chronic pain, they live with a degree of disability, and their lives become changed to a degree because of that. So programs of care, whether they're in the community or within healthcare, need to be designed to help in the following ways that are important. And of course, Kathy, you've done a phenomenal job on the evidence-based need of validating pain experience, how and why, and so that's a very strong, important point. Providing a multidisciplinary approach, which has been talked earlier about, especially when there's multiple things going on in a person's life, for diagnostics to better understand if there's an underlying condition that sometimes may even include a genetic thing, so a genetic condition. Provide educational materials to teach skills and provide tools to help them build coping strategies to cope, and then treat individuals as is done with the physical disabilities. And this is something that we do with our families through the ILC. It's about really helping them maintain or adjust to find what their passion is. You know, for the child, they're in school, they have to manage the courses, sometimes they have to adjust their school schedules, their extracurricular activities, and essentially help them build strategies to do the things that they enjoy doing, keep their schoolwork up to date, do those things well, and and to be able to participate in family and social life, and even in a volunteer capacity through their school programs. This is this next slide is one of the things that is a difficult thing. I always feel shy to talk about it because the pain experts have done tremendous work to understand chronic pain and have talked about chronic pain being a disease in its own right. And I wonder if that's really the right thing, that do we need to tease that out, which we're talking about anyway now. So pain that persists as a symptom that is something that it's a symptom that something is physically wrong. And the best 2 examples I can give, in one family that approached us for support, the individual was a grown person at this point, born with cerebral palsy, was a Paralympic gold medalist in track, racing in a high-performance racing wheelchair. She had visited the emergency department at her local hospital over 100 times in the course of a year, and was dismissed with the, you know, oh, she's attention-seeking, it's all in her head. They told us she had anorexia because she had lost a tremendous amount of weight. Prescribed opioids, antipsychotic medications, was told to go horseback riding, different forms of physiotherapy, and by the time they did any diagnostics, it ended up that she was diagnosed with end-stage cancer and she passed away. So that is a case that's being carefully reviewed in the legal system as well as in the in the hospital system overall. So there's accountability and responsibility that's being discussed, and it's all being done very collegially. There's no lawsuit happening, but really it's about human rights and why were there no diagnostics done. And then the other example is another Paralympic athlete with spina bifida. You know, as a 30-year-old, was treated tremendously as a child growing up through Thick Kids, Holland Floorview, the many programs for physically disabled people to participate in sport. This individual played sledge hockey on Team Canada. He also then went to track and ended up with debilitating headaches, shooting pain, brain fog, all the symptoms that we were used to hearing about the EDS population, and said, sounds like you might have a Chiari malformation, or maybe your shunt has failed. And they couldn't get anyone to look at them. All the neurologists and neurosurgeons that did look at the diagnostic reports had indicated there was nothing surgical. So you know, I approached a neurosurgeon at MAC who was interested in our difficult to diagnose disease program from a perspective of spina bifida in adults, and he agreed to see the patient, and he was diagnosed. He did have surgery, his shunt did fail, and he also had Chiari malformation. But he lost a whole year of being able to train and almost missed the ability to go to Rio. And the good news is he did go and he won a gold medal, so that was good. So in that same topic, you know, is chronic pain a disease in its own right? You know, are the 3 Ps of chronic pain management counterproductive to the Hippocratic Oath of do no harm? And we talk about physiotherapy, pharma, and psychology as the treatment, and diagnostics are not thought of at the front at primary care to get them, and when they're not educated on the different diseases that could exist and have those toolkits that we're working on creating, they're not doing those early diagnostics to be able to determine there could be something else going on. So, you know, my best example is, and this is one that one of our doctors uses, it's like without diagnostics, it's like seeing a patient with debilitating leg pain, prescribing opioids to help reduce the pain, telling them to think about the pain differently, do cognitive behavioral therapy and art therapy and music therapy and different things, and that it will go away on its own, and do physiotherapy without an x-ray to see that the leg is actually broken, and when left unaddressed properly will result in a lifetime of chronic pain, debilitating, and suffering.
I think this is an amazing point you're bringing up.
Thank you.
Yeah, and it's very frightening. And so, I mean, I think in some ways it speaks to the cognitive trap that health professionals are faced with whenever there's a disease that maybe even has a stigma, like mental health as well. Mm-hmm. You know, my mom was diagnosed with anxiety instead of a heart attack, and I think it would have been unlikely for that to occur in a male executive. You know, and as a result needed 12 stents in her heart and had a lot of complications. Right. But that's one of the pieces that we probably need to highlight, you know, that chronic pain is chronic, and if there's a change in the type of pain, the severity, the frequency, that it needs to be reviewed and appropriately investigated. Like people with migraine can get brain tumors. People with ADHD can get brain tumors. Right. And so, yeah, exactly. And so it doesn't mean that there isn't that chronic disease model possible, but that a person has to be ever mindful of whether or not there's a change in the character of the disorder, and that medical clearance is bogus. It never actually occurs.
Right. It's interesting. You know, I'm going to share a personal story. So in my family, we have a genetic condition called spastic paraplegia. Although genetically they said it was Charcot-Marie tooth disease, which is, both are known to be rare. So myself and two of my children, I passed it on to two of my children. One is Austin, who is on Team Canada, races in a high-performance racing wheelchair, and has had a phenomenal life being supported through Sick Kids, you know, the Air Note Kids. He didn't have to do a stint at Bloorview because he hasn't had to have any surgeries, but now as an adult, you know, he has a full life. He's at college. Does he have pain? Yes, he has pain, but he masks it and pushes past. Where my other daughter, you know, we went to the same doctors, the same specialist who's a neurologist who is world-renowned in neuromuscular conditions, and he completely dismissed and annihilated my daughter Olivia. And you know, he said, well, you've got spastic paraplegia. I've never seen that before. And if you've got, it was a terrible, terrible appointment. He dismissed the question that there could be something else going on, like maybe she has a tethered cord. And now, after all of the connections that I've made, you know, for our annual medical conference specific to EDS, I've learned that actually our family has tethered cord syndrome, and that manifested itself as spastic paraplegia because I also had a tethered spinal cord. And you know, had I went into the neurologist with the symptoms, had I been a male and went into the neurologist and said what my symptoms were, I would have been on the operating table the same day. I'm sure of it. But because my symptoms, I'm a female, they said nothing surgically indicated, and I had to actually go to consult with a specialist in the States and ask, is there anything going on with my spine? And they said, oh yeah, you clearly got a tethered spinal cord. So in Olivia's case, I'm still blown away, and it's hard to say the words, but she's actually been diagnosed with EDS, gastroparesis, orthostatic intolerance, probably has mast cell activation, tethered cord, and Dr. Shamji, of all people, diagnosed her with a Chiari malformation. So these things exist in people's lives, and they're completely overlooked because, oh, well, it's just part of your disease. You have spastic paraplegia. You can't possibly have anything else. You have, you know, cerebral palsy. How could you possibly have anything else? You wouldn't possibly have cancer. So I think my life story is like, it blows me away. I'm in this position. Yeah, I would much prefer, I am much better, Kathy, when you and I first met, advocating for other people is so easy. As soon as I start talking about my own 21-year-old child who's not in school, who is not doing well, is not able to work because of brain fog and stuff, I completely lose it. So we'll move on from this topic.
Thank you, Sandy. Yeah, and you know, the stories are what helps, right? And
yeah.
And I think as we go forward with creating tools, that's why our ebook is a story book about a family's journey, because the story paints the picture that is not there without the words, right? So
absolutely.
Thank you.
Good. Okay, we'll move on. So why connective tissue and EDS is important in understanding chronic pain? Well, connective tissue comprises 80% of our body. Chronic pain is a hallmark symptom affecting multiple systems. EDS is hereditary. It's an arthritic listed disease. It affects young and old alike. It is now estimated to affect 1 in 100 people as opposed to 1 in 5,000. So it's actually it's 50,000. Sorry, I missed a zero. I'll change that. So it's not rare, and I think we're recognizing that it's highly misunderstood and underdiagnosed as a cluster of a number of syndromes. There's 8 forms of EDS, with the most severe being vascular, that can be life-threatening. And this, the neuroplasticity of the brain, where does hope lie in the brain cortex? And this is something, again, with every family that we talk to, every individual that reaches out to us for support, because we don't only help children, parents and individuals are left feeling that healthcare professionals are the enemy. So I've gone from being a support person who provides peer support, a listening ear where I can validate their experience, to now, because of working with you and all of our medical advisors and really understanding where the gaps lie in the health systems that don't exist and the funding, the entire picture, I end up sounding like I'm defending the healthcare system because I know there's excellent work being done. We're not there yet, but there is excellent work being done. Our job, I think, working together is really to bring out the awareness and get that knowledge out to people, to let them know the good work that is being done. And, of course, educate the doctors to not say stupid things like, suck it up, buttercup, and that it's all in your head. So the individual's left anguished, the parent is, the care provider, the friends. There's a fear of being misunderstood and dismissed. And what ends up happening is fear of hope itself is what they end up fearing the most themselves, because they wait for that long wait list to see the specialist. They think this doctor's going to know. He'll be able to help. He'll say something about, he'll have some direction, and then they're disappointed. So how do we talk about giving coping strategies and how to help the patient communicate well with the medical health professional, because often those appointments go very bad. And so it's also giving them strategies for, you're going to go into this appointment, you're going to talk to the GI guy, don't talk to him about your headaches, you need to talk to him specifically about the GI issues. And if you start going on to all the many doctors that you've seen and everyone just dismisses you, and it's a big, it's without any forward momentum, it becomes an ineffective appointment, and the doctors are not really able to give the care that they need to give you and the attention. So this is, again, this is a whole topic unto itself, for giving a resource to the individual and the family for how they can be active participants in their care in a more positive way. And I think that's my last slide. Oh, the last slide is, this is somebody who has seen many, many people. They're not in school, not able to, it's just very, very challenging. They've seen cardiology, they've had prescribed, they've seen neurology, they've seen a neurosurgeon, and the neurosurgeon, says he's not able to help. You can refer to an orthopedic surgeon if you want a fusion, but I don't agree with those surgeries. You can wear an Aspen collar if that helps. This is somebody who is clearly not well, and there's neurological deficit, and this takes us to a whole other aspect where research needs to happen on developing evidence-based criteria for when is surgery indicated, or do you do a course of wear an Aspen collar, do physiotherapy with an osteopath, and find coping strategies to get you back into school, being able to have some social life, and know that there's a care plan that if at the age of 13 you're like this, if you're still like this in another year or things get worse, we will then look at surgery as an option. But to just dismiss the patient is this is what suicide ideology is born from. So to close, I'm just glad that we're working together, and look forward to creating a helpful toolkit that's more robust and speaks to that broad patient population.
Thank you, Steve.
You're welcome.
Yeah, thank you, Sandy.
You just discussed half the patients I see. They're so frustrated. They see so many specialists.
Yeah, you know what? Like it is the most. It's heart-wrenching. Like I, as care providers, you're in the healthcare system and in the community. It's so hard because, you know, there's people that contact us and they're, you know, they probably have a CSF leak. They have all the symptoms, or their experience is like mine. Like I saw 3 different neurologists and neurosurgeons in an ER setting because of an episode, and they all said no, there's nothing surgically indicated. And my neurologist said, you know, well, I'll get you in to see a specific neurosurgeon downtown Toronto. So I met with Dr. Yaw. He looked at the very same MRI and what came into the office and said, oh, it's very common. Women in their 50s get tethered cords. We know how to fix that. And I'm like, I was dumbfounded. And I said, what do you see that on my MRI, or is that something that is because of my symptoms? He said, no, it's clearly evident. He pulls up the screen. He shows me I'm tethered in 3 different places. He says, you probably lived with this your whole life. And then he opened my medical file and he said, oh, I got to tell you, you're not going to be a surgical candidate, because when I was 8, I was diagnosed with mild CP. When I was in my 20s, it was Charcot-Marie tooth disease. Then in my 30s, genetics advanced. It was spastic paraplegia, and I have a daughter that was diagnosed with EDS. He said, you're not going to be a surgical candidate. And so he took my file. They went to the UHN, put up my screen, my image, and discussed it with the senior neurosurgeons, and they agreed that they would take me on and do the surgery, which was successful, and that surgery took place in July. But you know, my experience is everyone else's. Those doctors don't want to take on the tough, complex patients because they don't really know if our dura is slow to feel like switch again. They don't have the expertise on the complex. I'm not complex, but somebody like Olivia was definitely complex because her dura was like tissue paper thin, like wet sewing, suturing together wet tissue paper. So Dr. Shamji had to put a biomesh in. And, you know, does her pain happen because she has a dura leak, a CSF leak? I don't know. And all these people are in the same boat. They come to you and they're not getting, they can't get to the doctors because, in fact, one of the outcomes of our conference is doctor by doctor, not just the surgeons. They're actually bullied in the hall by their peers for taking on the EDS, the complex patient. And it's we need to overcome this somehow. Anyway, this is a good conversation because we're all converted.
Yeah, you're in the right crowd here, but it's just to for us to reach out to that bigger audience and sort of craft the message that's going to get through. So
yeah.
Which is why for these complex kids, like Krista says, first referral from primary care has to be to a pediatrician who can at least, you know, have that understanding to be able to do that thorough history and physical examination, and then determine next steps, and then letting them know when to refer to a pain clinic. Because we accept referrals from GPs to our pain clinic as well. They don't all have to come from a pediatrician, but I have to tell you, probably half my referrals come from subspecialties.
But you know what's interesting? It's the simple things. Like if they have mast cell activation, for instance, mast cell mimics so many things and it causes pain. So a family physician or a pediatrician would be able to order tests, go see an allergist, number one, that would be the referral, but they could also do a test, it's a 24-hour urine study, and consult with the international experts on mast cell activation and what's being done. And the treatment is, it's almost instant. It's like an hour after they take whatever therapy, whether it's a medication or, and I don't know enough about this, I try not to be medical, there's almost an instant relief of pain and symptoms just by eating the right thing and taking the right supplements and having the right medications. It doesn't always have to be a big, huge thing. It's like orthostatic intolerance or POTS or syncope, right?